Hello, welcome, and thank you for joining SIO today for our very first webinar of 2023, Translating Clinical Guideline into Patient-Centered Oncology Pain Management. My name is Morgan Denault, and I am with the SIO staff for today's webinar. If you have any technical or audio questions, please feel free to send me a chat in the chat box. If you have any questions for our presenters today, who I will introduce here shortly, please send them through the Q&A box at any time. We will have time at the end of the presentation to go over all of the questions. This webinar is being recorded and will be available on the SIO YouTube channel for your viewing. Today, we have assembled a panel of experts who will discuss the impact that integrative medicine has on patients with cancer. With us, we have Jun Mao, Chief of Integrative Medicine at Memorial Sloan Kettering Cancer Center, and Ana Maria Lopez, Professor of Medical Oncology and Integrative Medicine and Nutritional Sciences at Sidney Kimmel Medical College, both co-authored on the new joint SIO-ASCO Clinical Practice Guidelines on Integrative Medicine for Pain Management and Oncology. Our third panel member with us today is Desiree Walker, survivor extraordinaire, two-time breast cancer victor, health educator, cancer patient advocate, and support group facilitator. Without further ado, please join me in welcoming our panel to the stage.
Next, please. So today I'm very honored to be joining the panel with Dr. Ana Maria Lopez and Desiree Walker to really talk about how can we translate our clinical guidelines into actual practice to improve the equity and quality cancer care for cancer patients. So next slide. So here's the disclosure for all the co-authors, part of the guideline process. Next slide. So the SIO-ASCO clinical guideline committee members for the pain guideline is highly multidisciplinary. I'm honored to co-chair the panel with Dr. Eduardo Barrera, who is the chair of palliative and integrative and rehab medicine at MD Anderson. And we have Dr. Aaron Ben-Air from Israel, Heather Greenlee from Fred Hutch, and Claudia Witt from Zurich, Switzerland. They represent the field of integrative oncology. We also have medical oncologists like Dr. Ting Bao, Dr. Ana Maria Lopez, Dr. Charles Loprinzi, and Dr. Gary Lehman. And nursing is a really important component of pain and symptom management in oncology. Dr. Deb Barton and Deb Schooner from Emory University also joined us. And there's a lot of sharing of common goals between integrated medicine and palliative care. So Dr. Thomas LeBlanc, Richard Lee, and Dr. Kavita Ramchandran also joined us from the field of palliative care. And in addition, representing psychosocial oncology are Dr. Eric Garland and Dr. Lynn Wagner. And we also have Dr. Eleanor Walker representing radiation oncology, Dr. Viraj Master representing surgical oncology. And we have ASCO guideline methodologist, Dr. Nafisa Ismailia. And last but not least, Jody McLeod, who is a SL secretary, also a patient advocate, joined us as a patient advocate. Next slide, please. So pain is a very challenging and common symptoms. It not only happens to cancer patients during treatment, can also lingering into survivorship. Pain not only negatively impact quality of life and daily function, can also lead to treatment non-adherence to life-saving cancer drugs such as aromatase inhibitors, as a result to compromise the overall cancer survival for patients impacted by cancer. Next. Effective management of pain can be incredibly complex and difficult. So, for example, the acute pain and chronic pain have different etiologies, and their presentation may be also different. There are neuropathic pain, such as chemotherapy-induced peripheral neuropathy, or more musculoskeletal pain resulted from surgery, radiation, or hormonal therapy. And some of the pain in patients with advanced cancer are driven by their cancer. For example, cancer invading organs or affecting the bones. And some are treatment related, such as chemotherapy, hormone therapy, or radiation. Last, as cancer patients often happen to individuals with other type of chronic diseases, such as osteoarthritis, chronic pain. So there could be also non-cancer related pain. Next. So we really need both pharmacological approach and non-pharmacological approach. Next, please. So previously, ASCO has published a guideline predominantly focused on pharmacological treatment as well as a rehab approach. There was a lack of guidelines for recommending use of an integrative approach to manage pain. So the SIO and ASCO joint guideline try to provide evidence-based recommendations on integrative approaches to pain management in cancer patients to practicing physicians and other healthcare providers. Next. So we used a very rigorous methodology, and the whole process took over a little bit over 2 years. Our first co-chair meeting started in May 2020, and then started September 2020. We convened our panel with literature search, analysis, drafted initial recommendations, and as well as review and revision, and also review by the ASCO guideline committees, as well as getting external feedback from the public. Ultimately, the guideline was published in September 2022. So we reviewed literature from 1990 to 2021, included systematic reviews, meta-analysis, randomized clinical trials. To enhance the rigor of this review, we did not include any non-randomized studies or case studies. So pain intensity, symptom relief outcomes, and adverse events from 227 relative studies were carefully reviewed, and we used the informal expert consensus process to develop the guidelines. Next, please. So here are the highlights of the guidelines. I really encourage people to read the full article because there are many rich information. For the sake of this presentation, we just focus on the key major guidelines emerged. The first take-home point is acupuncture should be offered to patients with aromatase inhibitors related joint pain. Aromatase inhibitors are a very common hormonal drug that prevent the conversion from testosterone to estrogen, therefore depleting the peripheral estrogen levels in women with breast cancer. As it's shown in multiple trials that it can prevent cancer recurrence and improve overall survival. Unfortunately, this type of drug causes up to 50% of users develop a joint aches, stiffness that cause a high proportion of patients have to stop this drug. So there are numerous clinical trials being included in the review. The very driving for the evidence is this large randomized trial published by Dr. Don Hirschman et al. Using the SWOG, randomizing over 200 women with breast cancer into true acupuncture, sham acupuncture, and weightless control. As you can see, the bar graph showing about 58% of the patients responded to the true acupuncture group for pain reduction. It was statistically significant, clinically relevant difference compared with sham and weightless control. And Dr. Hirschman's group lately also published that effects actually persist to over a year. So acupuncture not only produced clinically meaningful benefit, but the effect was also durable after the acupuncture treatment stopped. So next slide, please. The second is acupuncture can be recommended for general or musculoskeletal pain in patients with cancer. There were 8 clinical trials included. The overall level of evidence intermediate with the moderate strength of recommendation. Overall benefit outweigh the risk. The main score driving recommendation is from this large trial published in JAMA Oncology in 2021, led by our group, involving 360 cancer patients with chronic musculoskeletal pain. We studied two types of acupuncture, electroacupuncture and auricular acupuncture. As you can see, both the dark gray and the lighter gray, those are the acupuncture groups, resulted in clinically relevant reduction in pain compared with usual care, and that pain reduction was persistent over a 24-week follow-up period. Next slide, please. So the third recommendation is massage can be used for pain management during palliative and hospice care. And this is based on two randomized systematic reviews and 7 randomized trials with intermediate level evidence and moderate strength of recommendation. The largest trial today was published in Annals of Internal Medicine. It was a randomized trial comparing massage with simple touch control, so it's an active control, and involving 380 patients receiving hospice care. So what they found is the massage therapy led to immediate pain reduction for patients with cancer. There was no side effects involved. However, the effects of the pain reduction was not durable in 3 weeks follow-up period. So clearly we can see massage can lead to short-term pain improvement and mood improvement in patients with advanced cancer. Knowing how much suffering this patient population experience, so massage can be recommended for pain and mood improvement for patients living with advanced cancer. So next slide. Many cancer patients go through very painful diagnostic or procedure to manage their cancer. So this is a trial published involving 201 patients with hypnosis versus empathy control and standard care control in patients getting interventional radiology kind of intervention. So you can see the triangle, so that's the hypnosis group. During the procedural period, it has the lowest increase in hypnosis. So when we think about the attention control, such as empathy, actually led to even higher level of pain. So sometimes overcaring can also lead to higher pain reporting. So it definitely demonstrates the hypnosis effect have a specific efficacy beyond just being nice to a patient. And also you can see overall the relaxation again focus on the triangles. The anxiety have reduced substantially in the hypnosis group during the entire procedure period. So having a non-pharmacological intervention to help with pain and anxiety management can play an important role for cancer patients going through diagnostic procedures and interventions. So therefore, there's an intermediate level of evidence with moderate strength of recommendation with overall benefit outweighs the risk. So next, please. So there are a number of weak recommendations for yoga, guided imagery, as well as music therapy for a variety of pain settings. So again, this is largely due to the number of trials are few and the sample size are small and methodology are poor, such as using just weightless control. There's no active control. So clearly, this also highlights the potential future area of research. There are some currently large studies being conducted in this setting. So depending on the results, so maybe the guidelines can be updated in the future. Next, please. And so this is an algorithm ASCO and SIO developed. This really can be helpful for clinicians. For example, if you have a patient with aromatase reported joint pain, so the 12 grade are moderate strength recommendation. The blue is a lower quality, and the red are a weak strength modification. So based on that, you can see for that patient, we will recommend acupuncture first. If patient for some reason have no access to acupuncture or don't like needles, then yoga could potentially be a really good approach. Another example, for example, with general cancer pain, right? So both acupuncture and reflexology, that's like a foot massage, and massage can potentially be more on the front line of recommendation, followed by yoga or guided imagery or progressive muscle relaxation. So hopefully this type of algorithm can help a busy clinician recommend the therapy with the strongest evidence. Certainly that should be also aligned with patient preference and availability of the resource services as was called. Dr. Ana Maria Lopez and Desiree Walker will also talk about some of the implementation challenges and opportunities. So next. So here are several areas I really want to call attention for future research. For example, there were quite a bit of research outside of cancer showing mindfulness-based intervention can be really effective for pain management. However, there's inconclusive evidence for meditation-based intervention, largely because many of the interventions are not even designed to treat pain, let alone the trials that were for stress management. So many of the patients enrolled in the trials have very low pain baselines. So based on those factors, there's an inconclusive evidence to recommend meditation at this juncture. So future research is needed. Next. A second important area, many cancer patients desire to use natural products to help them to manage pain and symptoms. But currently, none of the natural products have enough evidence to even have weak or moderate recommendations. So clearly, some of the methodologies, such as small trials, high risk of bias, very different product and the inconsistent findings. So if you look at the full paper and supplemental materials, there are definitely promising agents, but we need larger trials, well-designed, controlled trials to increase the evidence base. I think this is the area we need more research. Next, please. And cancer not only affect adults, also affect children. So unfortunately, all the trials in children are very small and have major methodological flaws as well as a limitation in sample size. Certainly, the number of children with cancer is much smaller than adults. So some of the challenges are inherent, but still, I think we need better designed interventions and trials to increase evidence so we can more able to help children as well. There are parents and caregivers with cancer, so children can thrive during treatment and beyond treatment. Next. So develop the guideline is only the beginning. So clearly we need more clinical implementation so the research findings can become a reality for patients. We need future research, including rigorously designed implementation and dissemination research, targeting more diverse populations. We need to ensure the equity of care and research process. Insurance is important for coverage issues for our patients, also for our clinicians to refer to patients. Lastly, a lot of our oncologists and nurses know very little about integrated medicine. And so is our say acupuncturists and massage therapists also know very little about how to take care of oncology patients. So we need interdisciplinary education to help increase the competency of our providers. So I'm really honored to have Dr. Ana Maria Lopez, who is a really expert in many of the implementation health equity issues. She's going to talk about the clinical implementation.
Thanks so much. What a great presentation. And as Dr. Mao mentioned, being part of this guideline process is so critical to move our work forward from an evidence base But now that the guidelines are in place, what do we do from here? So next slide, please. So that's really the focus of this section. How do we translate the guidelines to the care of the patient that we'll be seeing? And how do we do this when we're practicing in integrative medicine, integrative oncology practices? And is there a way to even do this if we are primary care physicians in allopathic medicine, or medical oncologist or radiation oncologist? So how do we put this into practice? Next slide, please. And this is really a translational science, implementation science, and we're talking about then changing practice. And I'm sure all of us, go to meetings where at least one of my favorite parts of the meeting is on the very last day, where it's, what are you going to do on Monday morning? And that's kind of what we're talking about now. Next slide, please. So changing practice, all of you who are clinicians know it ain't easy. We know from the data that there's usually nearly a 20-year lag from the time the evidence is known until we actually change practice. So evidence-based practice change of any kind is disruptive. And we certainly have been through a disruptive period, so we know a lot about what that's like. And what's disruptive about it is that we need to unlearn our habits. And evidence can change, like we know that as clinicians, but we also we also know that we need to trust the evidence. So how do we trust the evidence? And it's also our behavior. And again, we all know that behavioral change is hard. And even though I may know it, the evidence may be there, that actually putting a different practice into place may be difficult. So all of those factors are factors that influence this 17-year lag. We need to unlearn habits, we need to trust the evidence, and we need to engage in our own behavioral change. Next slide, please. So how do we do this? And the thing is that there are lots of factors, and we don't practice, just unilinearly. We practice in context. So before we change our practice, we need to acknowledge the fact, hey, I thought I knew X. Maybe I thought that when somebody came in with aches from aromatase inhibitor, I might do X. But now I know from this guideline that acupuncture might be a consideration. So I need to acknowledge that what I thought I knew, actually there's new knowledge now. And then I have to think, how do I incorporate the change? And what we know that what really supports behavior change is to be in a supportive environment. So if all of our colleagues are saying, hey, did you see that paper? Aromatase inhibitors, we need to be considering acupuncture. That's supportive. If the institution puts into the electronic system, you've just noted that this patient has myalgias, arthralgias from aromatase inhibitors, perhaps consider acupuncture as an intervention. And if the patient, if we get to that point in having that support, do we know acupuncturists who can help take care of the patient? Do we have systems in place where the patient would be able to have insurance coverage for that intervention? So all of those factors in context can help facilitate the implementation. Interesting, we also know that if the new guideline prescription is to add something, that's usually easier for us. But if it's actually stop doing something, that it's difficult for us. So again, these are factors, contextual factors, that influence behavioral change that influence implementation of the guidelines. Next slide, please. So there can be facilitators for the patient, such as the patient, the recommendation would be covered by insurance. We talked about some of the facilitators for the individual clinician. First of all is knowing, that's one of the things about knowledge. It takes time to disseminate. So the first step, of course, is education. And if a group of people get the education together, that can be a supportive environment to then begin to make the changes if people trust the data and are interested in moving forward. The profession can support with the education by saying, like what we're doing now, having sessions, and they can be also, as we're doing now, interprofessional sessions, right? People with cancer are taken care of by a team of people. So education for the healthcare team. And the institution can do advocacy. Everybody can do advocacy. So for example, for the insurance coverage, and can implement reminders, triggers to help us as we make these changes, for example, in the electronic record. Next slide, please. So different facilitators, really, really important. And, trust, we've been through a period where so many of these terms, I think, really resonate, that as we work with our patients, and if we're to say, oh, you know what, we had thought of this as the intervention for some of your symptoms, but we now know X is something to consider. Patients want to be able to trust us, like, well, why? What just happened? And we want to be able to speak to that. So this constant, our engagement, our interaction with the patients, really foundational for that to be grounded in trust. Insurance access, again, that's just such a major issue for us in the United States. I know that SIO, this is global, and it may be, it's definitely different in other countries, but that's so pivotal for in the United States. So patient education, patient discussion groups, we'll probably, as we often do, patients come to us that because they've read the literature, and Desiree, I'll look forward to hear your comments on this. They've read the literature and they're talking about it on their Facebook page or on their forums, and saying, hey, your doctor recommended that. Maybe I'll ask my doctor about it. So patients are definitely engaged in those efforts, and we want to be able to be resources for them, educational, evidence-based resources. Next slide, please. Facilitators for the individual clinicians, we talked about education, and as people then try it, they'll have personal experience, and then people will share that. Hey, I tried this with my patient. I was able to reach this acupuncturist. Again, maintaining the example with the AI symptoms and acupuncture recommendation. And then it becomes a peer practice, a peer experience then can be shared. But really key is an openness to the change, as well as a perception of patients' openness to the change. So education for the clinician, experience of the clinician, and that part of the educational efforts can include some case-based discussion where people can experiment. Well, what would it be like to talk about that? What is it that I need to know, for example, about acupuncture before I make that recommendation to a patient? And then so important for us to hear, to listen back our patient experiences. How did they experience it? How did they get there? Next slide, please. Facilitators for the profession, we talked about bringing the education to the team, using interactive tools, providing tools for the conversations, because there may be gaps in our knowledge or gaps in our comfort level in talking about some of these efforts. So as much as possible, if we bring case-based education, that could be very helpful in facilitating. Next slide, please. in our institution, the prompts, best practice changes, and then again, being able to provide these facilitating factors at the point of care. And then we assess this, right? We say, did that work? Was it effective? Next slide, please. So different facilitators. The process of change is not just dependent on the clinician. It's not just dependent on the patient. It really is multifactorial. The different points where care is touched on, and how all of these interact. Next slide, please. And it's a learning experience. So I think as we think about this, think about how to facilitate this change in your practice, what the different touch points might be, what might work best for you. These are just thoughts that were, that I've just shared with you, but not all of those thoughts make fit for you. So go for the low-hanging fruit, and then see what works. See how it works for you. And part of the analysis is also, maybe it works really well for a part of your practice, but maybe it's more difficult for others in your practice. And part of, we always think about is who's being left behind, so that as we go through this process of learning, we may then say, okay, maybe we're not reaching this group. So what can we do to better reach that group? So always see what is happening, how your intervention worked, and who benefited, who was left behind. That allows us to redirect and optimize our efforts. Next slide, please. So really, as we go through this, I think it's an opportunity for us to learn together. Encourage you to send your implementation stories so we can learn together how best to move this forward. Guidelines are powerful, but let's see if we can shorten that lag phase from 17 years to something shorter. I'm not going to hold us to a target point, but I think we want to shorten that time point, because this is so useful for our patients. So share your stories, let's learn together, and really look forward to hearing your stories about how this worked. Next slide, please. Thank you very much. And next is the fabulous Desiree Walker, who will share from her perspective. Thank you.
Thank you, Dr. Lopez, for that introduction. And I would just like to also take the opportunity to thank Dr. Mao as well for being part of this effort to establish these guidelines. As a patient, a two-time breast cancer victor, I know how invaluable it is to be able to have guidelines to shape the work that is done for us. I'd like to just take a few minutes to really talk about the first slide before I move forward. Talked about the experts that were involved in the establishment of these guidelines. And I would just like to acknowledge that a part of those experts was a patient advocate, Jody McLeod. And I know that she represented and gave a great input and perspective for this work that has been done. And so I'd like to, also acknowledge the opportunity to be here today. We've heard from Dr. Mao and Lopez in terms of their view as clinician researchers, and now I have an opportunity to share some thoughts as a patient advocate. Next slide. I think that it's safe to say that the cancer experience can often bring pain. Sometimes it's not forever, but sometimes it's long lasting and chronic. And that affects quality to life. And it's important to know that we actually go to the clinician to seek remedies, to seek management solutions. But also at the end of the day, clinicians are always thinking about how they can effectively manage the pains that we potentially have. And so I think that it's safe to say that both cancer patients and clinicians would agree that an effective management of complex pain is critical. Next slide. And so these were, as I had the opportunity to review these guidelines, I would just share as a support group facilitator, this is good news for many because oftentimes acupuncture is not necessarily the go-to. It's not being offered. And so often patients do not want to have to take another drug after having taken so many different forms of drugs to deal with their cancer at the end of the day. And it's also real that there's often many times you may have to have procedures done. And so to be able to know that hypnosis can be offered in order to assist in that aspect is a great thing. As well as massage. So I appreciate these recommendations that have been highlighted about things that many are using and that they should be offered and the value through the science. Next slide. And so as a patient advocate, I often say, we need to understand the importance of research. And lots of great research is being done in the integrative oncology space, which is good. But the question that is often posed is who knows about it? And so, Dr. Lopez has spoken about ways that her colleagues can be educated. But I think that there's also an aspect of education that would be important for patients and patient advocates. And having these guidelines will now offer us an opportunity. One, oftentimes, some of our physicians are not able to attend the various conferences where these information may be shared or get through the literature themselves. So we have an opportunity where we can share with our physicians what is available now, what the knowledge is based on the research. But I think that it's also important to build connection with patient advocacy groups because they have the membership who will need this information. And it's also an opportunity for each of us as patients to teach others in the circles that we are in support groups as well. And it's really to get the information out so that we're increasing the knowledge of what is available so that it does not appear as hopeless as sometimes it feels when one is going through a great deal of pain. But I would also like to acknowledge that there is in these times, i.e. 2023, we have the opportunity to access social media and utilize it in order to disseminate as well. And so, this SIO being an international organization can actually be able to reach more people with the information utilizing social media, but we as advocates also have that as an opportunity as well. Next slide. I think that it's also important, yes, we need the research in order to inform us in terms of clinical practice, but we also need to focus on coverage, as Dr. Lopez mentioned, insurance coverage. And it's important to know that another role that advocates can play is regarding policy, legislation. And so I often say that, we need to know the research because that helps to support our discussions. Because at the end of the day, it is important to know that it's not just the clinicians that may need to be educated. It's not just the patients and the patient advocates, but also the policymakers need to be informed as well so that they can make better decisions about what bills they will sponsor, what change they would like to be able to help create for the patient, for the clinician, for the institutions, so that there is a better healthcare system. And I think that one of the things that's important to discuss, when you have the opportunity to meet with policymakers, not only just to tell your own particular story, to talk about fellow cancer survivors, but it's to emphasize the importance of quality of life. We are grateful as cancer survivors to have the various treatments, having the various drugs that may be available to assist us, but there are so many non-pharmacological options that we too would like to explore, because we know that the body was designed to naturally heal itself. And so in order to give that the opportunity and not have one additional pill to take or medication to take, it's important that we start to rethink how we move forward in cancer care. Next slide. And so I think that, we're always thinking about the future and trying to prepare. We've moved into a time where we're really trying to focus and have things be patient-centered, and to take into account the various individuals and what their challenges may be, and if they have to be on the cancer journey, to try to make it as pleasant as it possibly can. And so I think that, patient advocates, need to continue to be available. But I also think that it's important for clinicians and researchers to start to build the bonds and the relationships with patient advocates, to really start to talk about the ideas that either group has in order to shape future research, because we know that without the research, without the data, things come to a standstill. I think that through that relationship, patient advocates can definitely have an opportunity to be members of study teams in order to see studies from its inception through the dissemination of the information and results. But I also think that it's important for patient advocates to also see themselves that they are part of the change, and they should be part of the conversation that occurs with payers and clinicians and institutions. We have the opportunities to serve on advisory boards. We have the opportunity as it relates to institutions to be part of the community advisory boards or the patient advisory boards. And we should take these opportunities in order to have the conversations with those who are in the power to make change, so that they can always make sure that they understand the patient perspective when these decisions are being made. And it goes without saying that we also have the opportunity to be a voice for the underserved, so that all individuals who have been diagnosed will have access to equitable cancer care. And this should not just be something that is trending or a conversation, but it should be something that is achieved. Next slide. And so I would just like to again say thank you for the opportunity to share some perspectives, we look forward to answering your questions. And remember, each of us has a role to play in healthcare and making sure that it is equitable. And so to Dr. Lopez's comment earlier, at the end of this webinar, it would be important for you to think about not only the knowledge that you gained today, but what action will you be taking tomorrow? Thank you.
Thank you everyone for your impressive presentations. We will now open it up for Q&A. Those in the audience, if you have any questions for our presenters, please post them in the Q&A box of your Zoom panel.
So while we're waiting, Morgan, can I pose a question to Dr. Lopez?
Yes.
And my question is, I was definitely, I would say, taken aback to learn 17 years. That's a very long time for things to be implemented. And so my question is, how can we, in the partnership of, patient advocates and clinician researchers working together, who do we need to speak with in order to try and shorten this time frame? Because I would definitely say that most patients would not be privy to all of the things that go on or don't go on in the background and why things don't move as swiftly.
Thanks for the question, Desiree. And certainly welcome others' thoughts on this. I think as we've talked about, change is multifactorial. And it does require, first of all, just the recognition that I have learned something, and that I can make the connection between what I've learned into doing something different. It may be that the first couple of times a person sees something, maybe they're just not sure. And I think especially with something like this, where like referring someone to acupuncture, that may be something really new for a medical oncologist, for a radiation oncologist, for a surgical oncologist, for a primary care doc. So how can we help people to trust that that's a good recommendation? Now, patients have a great role in that, because patients can say, hey, you know what, I tried acupuncture for such and such, and it really worked for me. So there's so many ways. And then also to make it easier to remember, oh yeah, I did hear about that. And now my electronic system is saying, you just put this in, you might consider this intervention. So I think it is multifactorial, and it does take time, but if we can put in, if we can work all together and put in some of these reminders, it might help to shorten the lag time.
Thank you for that.
Don't have any questions yet from those in the audience.
So I had a question. And Dr. Mao, I know that, this was just one of several guidelines, and I wonder if maybe you might share a little bit about what the prior guidelines might have been and their impact, and what some of the future ones are that SIO is working on.
So SIO had a history of creating guidelines, and our most recent guideline prior to this is integrated therapies for breast cancer patients going through treatment. It was endorsed by ASCO, and that particular guideline is one of the most highly downloaded articles in the JNCI monograph, and also the CA Cancer Journal for Clinician has featured. So really it created a lot of sort of buzz that was sort of brought SIO and ASCO to develop a joint guideline. The next guideline will be on psychological distress. So it should be coming out either this year or next year. And then there's also effort on fatigue and sleep in the planning. I do think clinical guidelines play an important role to standardize the care delivery, and to elevate the recognition of integrated medicine as part of comprehensive pain and symptom management. So thank you for that question.
Do you have one question that just popped up? How do you foresee us moving towards insurance reimbursement for these interventions? What kind of models or practices might be most successful?
It is amazing because the NCCN guidelines, ASCO, there are lots of efforts. There's like this convergence about recommendations that are, maybe acupuncture, maybe meditation, maybe nutrition. And these are not always covered services. So I think partnering, educating our legislators, working together with patients on advocacy, and gathering more data, because one is, here's the recommendation, but are there cost effectiveness measures that we can add here? Are there long-term outcomes that we can add here? So having ongoing data, but I think a lot is about educating and partnering, working together around advocacy. Others may also have thoughts.
Yeah, the only other thought that I would just, like to add, and I guess it's putting in a plug, in a sense, the National Coalition for Cancer Survivorship, spends a great deal of time trying to understand what survivorship looks like and should look like today, and focus on policy and building the relationships with the lawmakers at the end of the day. And so I think, although, there is an opportunity for patient advocates to be involved, I do think it's an organization that anyone that is focused on advocacy and trying to make sure cancer policy moves can be a part of, because I think that every one of us needs to be connected in many areas in order to try to move this work forward, because we can't just stay on the research side, we can't just be on the legislative side, and we definitely need to make sure that we're doing the outreach, because I think we can't underemphasize the importance of education and knowledge to change.
I think one of the things that is important to know that changing insurance coverage is both difficult but yet possible. So I was actually involved with the process of getting acupuncture covered for chronic pain, low back pain by Medicare. It happened in early 2020 as the COVID pandemic started. So it didn't really get a lot of press coverage because it was, the universe is under such a chaos, right? So in the United States, we're experiencing our unprecedented level of opiate-related death and an epidemic pain, chronic pain. And in a sense, that's our opportunity, right? I do think cancer patients and survivors, because of the really challenging treatment they're undergoing, they're left with a lot of like pain. And because their kidney and livers often are also taking a hit during the treatment, and also many of them on blood thinners, they couldn't take too much sort of a NSAIDs. So they're left with almost nothing except for opiates. So I think as a society, we need to find ways to help people to alleviate suffering. Just improving somebody living longer is a great goal, but living longer with a lot of pain is not ideal. So I do think it's whenever you think about politics, it's also who you know, right? Like politicians, their loved one have cancer, they themselves have cancer. I think it really requires our patient advocate community and the clinicians, if you have contact, you know, give the researchers opportunity to present the research data. I would challenge anybody. There's more evidence on the use of acupuncture to treat chronic pain in cancer than opiate. Why is opiate covered but acupuncture is not, right? So it's not just about the research evidence. is about the financial power, and a lot of other things are led to many of the inequity of a healthcare. And I'm sure this is going to be on YouTube. I'll be in trouble. But at the same time, as a passionate physician wanting to help the patients who are living with pain, I'm going to put this out there. If somebody bring me more long-term data to show opiates providing long-term benefit for chronic pain cancer survivors, show me the data. And we put that side by side against acupuncture. Why don't we give patients at least a course of acupuncture to see if it helped them to manage their pain? Why are we so freely to prescribe opiates that can cause so much harm for themselves and potentially for their loved ones? I would challenge, can we use some of the opiate payment to pay for acupuncture for cancer patients? Those pharmaceutical companies are paying billions of dollars for the harm they're causing to the society. Just even using a very small proportion of that, we will ensure a lot of the cancer patients get some access to help to manage pain without reliance on opiate.
Mhm. Yeah, and I think your comments also speak a little bit to, again, this is new, right? That people are used, in medical school, we learned about opiates and how they convert, all of these things, but we didn't learn much about reflexology or acupuncture, and certainly about lifestyle things. So because it's not so familiar, really important for us to expose people, educate people, and do those advocacy pieces. So, and as you mentioned, because we're not familiar, there is kind of like we go to the familiar, that's the definition of bias.
And I would just add to that, that in addition to that, I think that what we have done is we've moved to a society that we want everything fixed quickly. And as a result of that, when we talk about, acupuncture and the other modalities, it's not like a pill, right? That in 30 minutes, 15 minutes, you're going to start to feel different. You may not really be better, you just may be zoned out, but you feel different, right? And I think that that's one of the things that we really also need to think about in terms of what we value, what our mindsets are, how open are we to say, are we giving people an opportunity to feel empowered after a cancer diagnosis, because they're making choices about treatments that are helping, but they're not harming, and they're still able to function. Because a lot of times, the prescriptions that you're given, they may make you feel different, but you're not able to live life fully or do the things that you love. And so I just think that it's definitely a mind shift that we would need to start making the changes that would be important, and having the different conversations at the end of the day. But I do thank you, Dr. Mao, and Dr. Lopez, for all that you've shared, and your continued persistence to make it better.
Thank you all for your time today. With us reaching the top of the hour, we will close it out here shortly. I see a couple echoes in the chat from our attendees, some thank yous. And just want to remind everybody that this webinar will be posted on the SIO YouTube channel. If you are interested in finding more about SIO's resources, please scan the QR code that you will be brought to our website to find all the information about SIO's benefits and resources and more recordings and more. Thank you all for joining us today.
Thanks very much. Thank you.
Thank you.